Spinal cord injury, Chapter 37. So what is happening in the body? There's a primary mechanism of injury, either hyperflexion, hyperextension, axial loading or vertical compression, excessive rotation, or penetrating trauma. So hyperflexion is the sudden and forceful acceleration of the head forward causing extreme flexion of the neck. The causes can be a head-on collision in a motor vehicle collision, a diving accident, or lower thoracic and lumbar spine from fall on the buttocks. Hyperextension is vehicle collisions from behind or when the patient falls and strikes their chin. The head is suddenly accelerated and then decelerated. Axial loading, also vertical compression, is from diving accidents, falls on buttocks, or a jump in which a person lands on their feet. A blow to the top of the head can also cause an axial loading compression. Excessive rotations when injuries are caused by turning the head beyond the normal range. And then penetrating trauma is classified by the speed of the object causing the injury. Low speed or low impact injuries damage directly at site or local damage to spinal cord or nerves, such as a knife wound. High speed injuries cause both direct and indirect damage, such as a gunshot wound. The level of injury is referred to by the letter and number of the vertebrae at the injury site. The 7 cervical vertebrae are classified as C1 through C7. The 12 thoracic vertebrae are classified as T1 through T12. And the 5 lumbar vertebrae are L1 through L5. There are 5 sacral vertebrae represented by S1 through S5. Sensory perception and mobility assessment. You want to assess mobility and sensory perception to determine the level of injury and establish baseline data. The level of injury is the lowest neurological segment with intact or normal motor and sensory function. Tetraplegia, or quadriplegia as is also known, is paralysis, and quadriparesis is weakness that involves all 4 extremities. This is seen with cervical cord and upper thoracic injury. Paraplegia, or paralysis, and paraparesis, weakness, involve only the lower extremities. This is seen in lower thoracic and lumbar sacral injuries or lesions. Labs and tests. You'll perform the basic laboratory studies, X-ray series, spine and the CT and MRI. The spine CT and MRI are performed to determine the degree and extent of damage to the spinal cord and detect the presence of blood and bone within the spinal column. Nursing interventions and treatment. You first want to obtain a pertinent history and injury details. These are listed on page 922. History includes how the accident occurred and the probable mechanism of injury, like location and position of patient immediately after the injury, symptoms that occurred immediately with the injury, and then changes that occurred subsequently. What type of immobilization devices were used, and was there any problems that occurred during stabilization and transportation? What treatment was given at the scene or in the emergency department, such as IVs and medication, IV fluids and medications? What's their medical history? Do they have a history of osteoporosis, arthritis of the spine, congenital deformities, cancer, any previous injury or surgery of the neck and back? And are they having any respiratory problems? During the immediate care of the patient with a suspected or confirmed cervical spine injury, a hard cervical collar is placed to stabilize the spine until a specific order indicates that it can be removed. Until the spinal column is stabilized, a jaw thrust maneuver is preferable to a head tilt maneuver to open the airway should the patient need an airway intervention. And you want to maintain spinal alignment at all times with log rolling to change position from supine to side lying. Some other nursing interventions and treatments. We must utilize the ABC priority framework upon the client's arrival. Secure the client's airway and assess breathing. Clients who have a high cervical cord injury frequently require ventilator support with mechanical ventilation via tracheostomy. Clients who have a lower cervical and thoracic spinal cord injury may require temporary ventilator support for mechanical ventilation with weaning to independent breathing. Complete respiratory assessment, including your pulse oximetry, should be done frequently. An oxygen sat of 92% or less and adventitious breath sounds may indicate atelectasis and pneumonia. The next priority for the nurse is dysfunction of the cardiovascular system. Nurses must frequently monitor for hemorrhage, spinal shock, or neurogenic shock. Nurses should continue to prioritize care for a secondary spinal cord injury due to hypoperfusion of the spine, as well as evaluate motor and sensory perception to document the level of injury. Evaluate the pulse, blood pressure, and peripheral perfusion such as pulse strength and capillary refill for any evidence of hemorrhage. And a systolic blood pressure below 90 requires treatment because lack of perfusion to the spinal cord could worsen the patient's condition. We're going to use the Glasgow Coma Scale to assess the patient's level of consciousness for trauma clients. A client who has spinal cord injury can also have additional neurologic issues such as a traumatic brain injury. The Glasgow Coma Scale assesses 3 areas: best eye response, best verbal response, and best motor response. A score to 3 to 8 indicates severe traumatic brain injury. 9 to 12 indicates moderate TBI, and 13 to 15 indicates mild. This score is an accurate indicator of clinical outcome, with changes in motor response the most important indicator in severely impaired clients. You want to perform a GI and GU assessment and assess for any internal bleeding, abdominal distension, pain, or paralytic ileus. Patients with cervical or high thoracic spinal cord injuries have upper motor neuron damage that spares lower spinal reflexes, causing a spastic bowel or bladder. Patients with lower thoracic and lumbosacral injuries usually have damage to their lower spinal nerves and therefore have a flaccid bowel and bladder. Also assess their psychological assessment. Assess patients for their reaction to the injury and provide opportunities to listen to their concerns. Be realistic about their abilities and projected function, but offer hope and encouragement. Aggressive rehabilitation can help most patients live productive and independent lives. Assess for coping strategies, pre-injury psychosocial status, their level of dependence, their support system, and spiritual culture beliefs. For surgical management, it usually involves spinal fusion to stabilize the spine and prevent further injury. So post-op interventions, we're going to assess their neurological status and vital signs at least every hour for the first 4 to 6 hours. You want to complete your assessments carefully and document them in detail. Failure to do so may prevent other staff members from quickly recognizing deterioration in neurologic status. For thoracic and lumbar fusions, metal or steel rods, such as Harrington rods, are used to keep the bone ends in alignment after fracture reduction. After surgery, the patient usually wears a molded plastic support, cervical or thoracic, lumbar, or both, to keep the injured and operative areas immobilized during recovery. The patient may be placed in a halo fixator device to maintain vertebral alignment, facilitate bone healing, and prevent further injury. Often after surgical stabilization for 6 to 12 weeks. This static device is affixed by 4 pins or screws into the outer aspect of the skull and is connected to a vest or jacket, pictured on the slide. So just remember, with a patient wearing a halo device, we never want to move or turn the patient by holding on or pulling on the halo device, and we do not want to adjust the screws. We're going to check the patient's skin frequently to avoid any pressure injuries. Pressure is avoided if you can insert one finger easily between the jacket and skin. We're going to monitor their neurological status for changes in movement or decreased strength, and encourage them not to use sharp objects to relieve itching under the vest, as it can cause skin breakdown. Some common complications from the halo device are pin loosening, local infection, and scarring, and some less common serious complications include osteomyelitis, subdural abscess, and instability. So we want to monitor those patients for any signs and symptoms of infection and report any changes to the primary care provider, and then provide pin site care as directed. usually including saline solution, maybe possibly even Vaseline gauze dressing. The pins are not usually routinely loosened, only if emergency access to the chest is needed, and the vest is not routinely removed for bathing and sleep. Medications. Because spinal cord injury is a physical trauma, the patient is started on a proton pump inhibitor such as pantoprazole to help prevent the development of stress ulcers. This drug may be administered IV or orally, and oral doses may be taken with or without food. An anticoagulant may be given as part of the VTE prevention protocol, and bulk-forming laxatives or stool softeners are given to prevent constipation. Calcium and biphosphonates may prevent the osteoporosis that results from lack of weight-bearing or resistance activity. Osteoporosis can cause fractures in later years. Centrally acting skeletal muscular relaxants may help control muscle spasticity. Baclofen, intrathecal baclofen therapy, may be prescribed to treat muscle spasms. Bowel and bladder retraining, including adequate fluids, 1.5 to 2 liters each day, and stool softeners are used to prevent constipation as well. Risk factors of spinal cord injury include trauma, falls, acts of violence, and sports or recreational related accidents. Complications. Secondary injury worsens the primary injury and may result in death. These include hemorrhage, which is a result in shock and decreased perfusion to the spinal cord; ischemia, lack of oxygen, typically from reduced absent blood flow; hypovolemia, you have a decreased circulating blood volume; impaired tissue perfusion from neurogenic shock, which is a medical emergency; and local edema. Both primary and secondary injuries contribute to capillary compression and cord ischemia. So shock. Spinal shock is not the same as neurogenic shock. Spinal shock occurs immediately as the cord's response to the injury is complete but temporary loss of motor, sensory, reflex, and autonomic function. It often lasts less than 48 hours. There's a decreased heart rate, increased blood pressure, pale ash gray or flushed skin. The spinal shock is transient, and recovery of some functions typically occurs. In neurogenic shock, loss of blood vessel tone, so dilation, after severe cord injury may result in hypoperfusion. So here's a table that shows the difference between spinal shock and neurogenic shock. With neurogenic shock, it's sudden loss of the sympathetic nervous system, most commonly with injuries above T6. It can cause hypotension, bradycardia, motor function varies, and the timing is soon after the injury. And mechanism of injury, there's a disruption of the autonomic pathways that leads to loss of sympathetic tone and vasodilation. With neurogenic shock, the nurse must monitor for manifestations of neurogenic shock by assessing their heart rate, blood pressure, and oxygen saturation hourly. You want to also monitor for temperature dysregulation, which includes warm or flushed skin, reduced level of consciousness, and decreased urinary output. For clients with neurogenic shock, a mean arterial blood pressure of 85 to 90 must be maintained to prevent a reduction in cardiac output and prevent ischemia to the spinal cord. For insertion of a large bore IV line should occur. You want to maintain adequate hydration through IV therapy and oral fluids as appropriate. Dextran, which is a plasma expander, may be used to increase capillary blood flow within the spinal cord and prevent or treat hypotension. Atropine sulfate is used to treat bradycardia as the pulse rate falls below 50 to 60 beats per minute. And continuous IV vasopressors such as norepinephrine or dopamine is used to treat hypotension. Autonomic dysreflexia. So some key features of it is sudden, significant rise in systolic and diastolic blood pressure accompanied by bradycardia. There's profuse sweating above the level of the lesion, especially in the face, neck, and shoulders. that rarely occurs below the level of the lesion because of sympathetic cholinergic activity. Goosebumps will appear above or even possibly below the level of the lesion. There'll be flushing of the skin above the level of the lesion, especially in the face, neck, and shoulders, blurred vision, spots in the patient's visual field, nasal congestion, onset of severe throbbing headache, and a feeling of apprehension. So what occurs? So there's a stimulant below the level of injury that initiates the sympathetic response in the body, causing vasoconstriction and increased blood pressure. And the nervous system is unable to compensate. The systems must work together, but they need healthy, intact spinal cord for that communication to occur. So you have something that, such as urine, that's filling the bladder. Catheter blockage means too much urine that fills the bladder, causing distension. And then the stretched bladder sends nervous impulses to the spinal cord. And when the impulses reach the level of T6, the sympathetic neurons become activated and release chemicals called norepinephrine. These chemicals cause the blood vessels in the skin and abdomen to constrict, and this makes the blood pressure rise. The rise in blood pressure is detected by sensors in the heart and neck called baroreceptors. These then signal to the brain. Now, the brain has two ways it can impose the rise in blood pressure. First, it sends messages via the parasympathetic vagus nerve to the heart to slow it down. And finally, the brain sends messengers down the spinal cord to make the blood vessels open up again. Unfortunately, the injury to the cord stops these messages, so only the blood vessels above the injury dilate. This is not enough to overcome the constricted vessels below the injury level, and so the blood pressure continues to rise. Specific risk factors are bladder distension, urinary tract infection, scrotal compression, bowel distension or impaction from constipation, irritation of hemorrhoids, pain from too tight clothing, contact with hard or sharp objects, and temperature fluctuations. Causes, think of the 3 B's: bladder, bowel, and breakdown of skin. You need to decrease the blood pressure to prevent a cardiovascular accident, seizure, or death. So treatment of autonomic dysreflexia, PDA, prevent, detect, act. You want to prevent by assessing for those 3 B's: bladder, bowel, and breakdown. You want to detect by assessing the blood pressure and monitor for any increase and assess for a presence of a headache. And then act. Elevate the head of bed 90 degrees to a high Fowler's position with the legs lower to decrease blood pressure. This is the first priority, is to place the patient in a sitting position or return to a previous safe position. Then you want to assess for, remove, or manage the cause. So remove any restricted clothing, check for any urinary retention or catheter blockage. If there's a catheter, check in the tubing for any kinks or obstruction. If there's no catheter, check for bladder distension and catheterize immediately if indicated. Determine if a UTI or bladder calculi, so bladder stones, are contributing to the genitourinary irritation. Check the patient for fecal impaction or other colorectal irritation and disimpact if needed. Examine the skin for new or worsening pressure injury symptoms. Monitor the blood pressure every 10 to 15 minutes. And then give nifedipine or nitrate as prescribed to lower the blood pressure as needed. Patients with recurrent autonomic dysreflexia may receive clonidine and another centrally acting alpha agonist agent prophylactically. And if needed, you may initiate the rapid response team. So complications. Patients with spinal cord injury are at risk for pressure injuries, venous thromboembolisms, VTE, contractures, orthostatic hypotension, and fractures related to osteoporosis. So what strategies do we do to utilize to decrease their risk? Frequent and therapeutic positioning. We want to reposition them every 1 to 2 hours. reduce pressure on those reddened areas. If they're sitting in a chair, encourage them to reposition more frequently. Use a pressure-reducing mattress or wheelchair or chair pads. Pneumonic compression stockings and low molecular weight heparin can help with VTE prophylaxis. Have them change position slowly to help prevent orthostatic hypotension. Teach mobility skills and bed to chair transfers, like the use of a sliding board or slider as it may be called. Splits and range of motion exercises could be used to prevent or minimize contractures. And then you want to consult with PT, OT, their rehabilitative team, to collaborate with them for different exercises and how best to mobilize or maintain mobility of this patient. For patient teaching and management prevention, you want to teach the client to avoid the risk. Use protective measures like wearing seat belts, avoid substances, and then the danger of diving. They shouldn't dive into shallow water. The action alert on page 924 talks about immediately following a spinal cord injury, we should assess breath sounds every 2 to 4 hours during the first few days and document and report any adventitious or diminished sounds. Monitor their vital signs with pulse ox and intervene if their O2 is less than 95%. And then watch for changes in their respiratory pattern or airway obstruction. We also want to teach the patient who is tetraplegic to coordinate cough effort with an assistant. The nurse or other assistant will place both hands on the upper abdomen over the diaphragm and below the ribs. The hands are placed one over the other, with the fingers interlocked and away from the skin as pictured. Then you would have the patient take a deep breath and cough during expiration. The assistant locks elbows and pushes inward and upward as the patient coughs. You're going to repeat that process until their airway is clear and provide rest periods as needed between. The primary purpose of rehabilitation for spinal cord injury is to enable patients to function independently in their communities. So during rehabilitation, clients learn about self-care, mobility skills, and they work on bowel and bladder retraining. A typical stay is 1 to 2 months. Sexuality and fertility after spinal cord injury depend on the level of the injury and whether the injury is classified as complete or incomplete. Spinal cord injuries can affect how clients feel about themselves, so it's important for clients to understand that an intimate relationship is still possible following their injury. Clients who have spinal cord injuries must learn to adjust to disability as a lifelong process. They'll have role change adjustments that may be difficult to reconcile. Depression and anxiety are common reactions to physical and emotional changes following injury. And some clients will need to have psychosocial support and possibly antidepressant medications. They should also be evaluated for suicidal ideation. Clients who have a spinal cord injury age faster than those without these injuries. Spinal cord injuries affect the endocrine, cardiovascular, and musculoskeletal systems, and clients with SCIs are more likely to have bone loss, chronic pain, kidney stones, and pressure injuries. So we want to educate the patients about what they need to know about aging with a spinal cord injury, and they're listed on page 929 in your book. So things like educating them to get their adult vaccinations. Females should have pap smears and mammograms done as prescribed and routinely. They should prevent osteoporosis by vitamin D and calcium intake, avoiding caffeine, no smoking, and then performing exercises against resistance. They should provide meticulous skin care and then look for ways to prevent constipation, and then modify activities if they begin to have joint pain, such as going from a manual wheelchair to an electric wheelchair. And that concludes my lecture. Thank you.